Welcome back to the deep dive. Today, we're on a very specific mission. This is a high-yield revision session for all you plastic surgery residents staring down the barrel of your board exams.
Yeah, we're talking FRCS, that kind of level.
Yeah.
And the topic is a big one. It's a guaranteed question.
Absolutely. Mandibular resection and reconstruction. We are cutting all the fluff and getting right to the core principles.
You just can't hide from the mandible. You have to know the pathology, the options, the whole decision tree.
Exactly. So we've pulled together the essentials for you. But one quick thing before we start. For those of you who want to go even deeper, our journal club and clinical cases sessions.
Where we really get into the messy, real-world scenarios.
Right. To get those, you do need the premium subscription. That's where we apply all this theory.
And for everyone else, if you're finding this useful, just take a second to rate the show. Maybe leave a comment on what topic you want next. We genuinely build the schedule from that.
Okay, that's it. Let's get to it. Before we can talk about taking the mandible out, we have to understand how the tumor gets in. Pathology. How does squamous cell carcinoma invade this bone? Because it's not random, is it?
No, not at all. It follows a very clear path of least resistance. And the first concept you have to nail down is the barrier, the mandibular periosteum.
Okay.
It's not just a wrapper. It's a tough, fibrous layer that is surprisingly resistant to tumor spread. That's your first line of defense.
But tumors do get in, and the way they get in is completely different if the patient has teeth or not. So let's start with a dentate mandible.
Right. So in a jaw with teeth, the teeth themselves are kind of a barrier. The tumor can't just chew through enamel.
So it has to find another way.
It does. And that way is the tooth socket. It tracks down the periodontal ligament. That's the weak point.
So the socket is the highway into the bone for a dentate patient.
Exactly. Now compare that to an edentulous patient, someone with no teeth.
The whole landscape changes.
Completely. The invasion is still from the occlusal surface, the top, but think about what's happened to the bone. Atrophy.
Right, the alveolar bone resorbs. The whole jaw shrinks in height.
And that means the distance from the mucosa on top to the medullary space, the marrow inside, is way shorter.
A much easier journey for the tumor.
A much, much quicker invasion.
Okay, now for the big curveball that every exam question loves to throw in. Radiotherapy. How does a history of radiation change everything we just said?
It obliterates the barrier. That's the key takeaway. Radiotherapy damages the periosteum. It becomes fibrotic, hypovascular.
So it's not a barrier anymore.
It's not. In an irradiated mandible, the tumor can invade directly through the cortical bone. It doesn't have to look for a socket. It just goes straight through.
That is a critical point. So if they've had radiation, the old rules don't apply.
They do not.
So once the tumor is inside the bone, how far does it spread?
This is a number you just have to memorize. The data shows that the spread inside the cancellous bone, so side to side, is usually only about 5 millimeters beyond what you can see in the soft tissue.
Only 5 millimeters. That seems surprisingly contained.
It is. But, and this is a huge, that only applies to the bone itself. If the tumor gets into the inferior alveolar canal, then all bets are off. The inferior alveolar nerve is a superhighway for perineural spread.
And it can go all the way to the skull base.
Exactly. So the bone spread is limited, but the neural spread can be massive. You have to check that nerve.
Okay, so let's translate that into the OR. We're planning our cuts. Resection margins. What's the rule?
The standard rule, based on that 5 millimeter data, is you take 5 to 10 millimeters of bone beyond the edge of the soft tissue tumor.
So if the tumor stops here, you cut the bone a centimeter past it.
Correct. That's your safety margin.
And what if the tumor isn't even touching the bone? Let's say it's close, but there's a gap.
There's a distance rule for that. If the tumor is more than 1 centimeter away from the bone, you generally don't need to do any mandibular resection at all.
You can just peel the soft tissues off.
Yep, the bone can stay.
Okay, but what about that gray area, less than a centimeter away? Or maybe it's just touching the periosteum. That brings us to marginal resection.
Right, so a marginal resection or a rim resection is where you're essentially shaving off the top of the mandible. You take the alveolar ridge.
But you leave the bottom border intact.
Exactly. You preserve the continuity of the arch. And, very importantly, you spare the inferior alveolar nerve.
So when is this indicated?
2 main times. 1, if the tumor is less than a centimeter from the bone, so you're taking that bit of bone to get your margin. Or 2, if the tumor is on the gingiva or periosteum and you suspect there's a little bit of invasion.
Now, this is the classic exam trap. When is a marginal resection absolutely the wrong thing to do?
2 scenarios. You must not do it. First, an edentulous mandible with a lot of resorption.
Because there's just not enough bone left to be stable.
Exactly. If that mandible is, say, less than a centimeter high and you shave some off, you're just asking for a fracture. It's too weak.
So if it's a skinny atrophic mandible, you have to take the whole segment.
You have to. Second contraindication, the irradiated mandible.
Back to radiation again.
Yep. The spread is unpredictable and the healing is terrible. You just can't trust a marginal resection in a radiated field.
Yeah.
You got to go segmental.
Perfect. So that brings us to segmental resection, the full thickness cut.
The through and through. Indications are pretty clear here. The tumor is fixed, or you can see it's frankly invaded the marrow of the bone.
And what's the plan for the nerve in a segmental?
You have to assess it. Best practice is to take the distal end of the nerve and send it for a frozen section.
And if it comes back positive?
You keep chasing it back. You have to extend your bony resection until that nerve is clear.
Okay, so the tumor's out. We've got a defect. We need a way to describe it. HEL classification.
The Jura classification. It's the standard. Simple, effective, HCL.
Let's run through them. C?
C is central. That's the segment between the canines, the chin, basically.
Yeah.
L is lateral, so that's the body and angle posterior to the canine, but, and this is key, it excludes the condyle. The joint is still there.
And H?
H is hemimandible. That's the lateral segment plus the condyle. So you've resected the joint.
And in the real world, it's almost always a combination.
Oh, yeah. You'll see an LCL, which is angle to angle, or an LC. It just gives you a quick mental map of what you need to build.
Which brings us to reconstruction. And the gold standard today is free tissue transfer. Let's start with the absolute workhorse.
The fibula free flap. If you don't know the fibula inside and out for your exam, you are in deep trouble.
So why is it so good? What makes it the king?
Number one is length. It's the longest piece of vascularized bone you can get, up to 25 centimeters. You can rebuild anything.
And it's the blood supply that lets you shape it.
That's the secret sauce. It's a Mathy-Sanahi type V-flap, which means it has a main pedicle, the peroneal artery, but it also has these segmental blood vessels running all along the bone in the periosteum.
And that means you can cut it into multiple pieces.
Without killing them, exactly.
Yeah.
You can make multiple osteotomies to create the perfect curve of a new jaw, and each little piece stays alive.
What about soft tissue?
You can take a skin paddle with it, supplied by septocutaneous vessels. It's very reliable. The one downside is height.
Right, it's a pretty thin bone.
Yeah, you get maybe 10, 15 millimeters of height.
Right.
So you often need to do a double barrel technique where you fold it on itself to get enough height for dental implants.
Good point. Okay, next on the menu, the DCIA, deep circumflex iliac artery flap. The hip bone?
The iliac crest, yep.
When do you pick this over the fibula?
The DCIA really shines for a hemimandible defect, an H or an L defect. The natural curve of the iliac crest is almost a perfect match for the mandibular angle and body.
So you might not even need an osteotomy.
Often you don't. The sheep is already there.
Sounds great, but it's not the workhorse. So what's the catch?
The donor site. It's a big, bulky harvest. You're taking a chunk of hip bone. Patients can get hernias. They can have trouble walking, numbness over the hip. It's just more morbid.
And the skin paddle isn't great either, is it?
It's notoriously unreliable compared to the fibulas. It's bulky, and the blood supply can be tricky. You can, however, take the internal oblique muscle with it, which is good for lining the inside of the mouth.
Okay, let's move up the body. The scapula flap.
Based on the subscapular axis, this flap is an absolute beast for soft tissue. You can take a huge skin paddle, latissimus muscle, serratus muscle, and about 14 centimeters of bone from the lateral border.
So decent bone, but amazing for soft tissue. What's the problem here?
Logistics. Purely logistics. The patient has to be on their side or on their front to harvest it.
Which kills the two-team approach.
It does. You can't have the head and neck team resecting while the recon team harvests. It has to be sequential. Resect, flip the patient, harvest, flip back. It adds a lot of time to the surgery.
A huge hit to efficiency. Okay, last of the big four, the radial forearm. We think of it for soft tissue, but it can include bone.
It can, but it's really not a primary choice for the mandible. You can take about 10 centimeters of bone, but you're limited to about 40% of the radius's cross-section.
And the bone itself isn't great, is it?
It's very thin, very low height, and the big risk is a fracture of the donor arm. You create a major stress riser in the radius.
So it's a salvage option, really.
It is. For very specific small defects where you need a super thin skin paddle and just a tiny shred of bone.
Okay, that's the free flap hierarchy. But what if the patient is too frail for a 10-hour surgery? What are the alternatives? Let's talk pedicled options.
These are your lifeboat options for sure. You can, for example, rotate a piece of the clavicle up based on the sternocleidomastoid muscle.
That sounds tenuous.
It is. Or the spine of the scapula on the trapezius. or even a piece of rib on the pectoralis major. But the arc of rotation is limited, and the blood supply isn't as good as a free flap.
What about just putting in a piece of non-vascularized bone, like a rib graft?
It's really not a good idea in this setting.
Yeah.
Non-vascularized bone needs a healthy, well-perfused bed to survive.
And after a cancer resection, especially with radiation,
That bed is gone. It's a hostile environment. The graft is just going to get infected or resorb. It's doomed to fail. Historically, people use trays packed with bone chips, but that's really fallen out of favor.
so that leaves us with the last option. A reconstruction plate with no bone at all, just a big metal bar.
A valid option, but for a very specific patient. You take a heavy, load-bearing plate, and you just bridge the gap.
Who's the right patient for just a plate?
Someone who is medically unfit for a big flap. Someone with a lateral defect, an L defect, is better than a central defect.
Why not central?
Because if you put a plate across the chin with no bone, the soft tissues just contract over it, and the plate will eventually erode right through the skin. It has a really high failure rate there.
And the other absolute no-go for a plate-only reconstruction.
Radiotherapy. If you radiate the skin over that metal plate, the risk of it extruding, of it poking through, is incredibly high.
Plus, with a plate, you're giving up any hope of dental rehabilitation.
Completely. You're providing structure, but not function.
So to recap the hierarchy, what's the big picture for our listeners to take into the exam?
The hierarchy is crystal clear. Free tissue transfer is the mainstay. Fibula is your default. DCIA for specific curves if the donor site is acceptable. Scapula if you need a mountain of soft tissue and can accept the time hit.
And everything else is a compromise.
Everything else, plates, pedicled flaps, is a compromise based on patient factors and what's safe.
So here's a final thought to leave you with. We have these amazing reconstructive tools now. We can build almost anything. Does our ability to rebuild so well ever tempt us to take wider margins than we strictly need? Or, on the flip side, does the complexity of a free flap sometimes make us hesitant to offer surgery to a palliative patient who might just want a simple plate so they can eat normally for their last few months?
That is the art of it, isn't it? It's that balance between oncologic safety and true quality of life. It's not just about what we can do, but what we should do for that individual patient.
And if you want to see how those complex decisions play out, make sure you're on the premium feed for the Clinical Cases Deep Dive that's dropping later this week.
And please, do rate the show. It genuinely helps us know what you find useful.
Until next time, keep digging deeper.